Good morning and welcome, everyone. I'm calling the 445th Council meeting to order. Thank you for joining us today. Just a quick reminder, Council members, to please have your video on during the meeting and mute yourself if you are not speaking. And to all who are live streaming this meeting through the RCDSO's YouTube channel, welcome, members of the public, profession, and other interested parties who are here to watch our proceedings. And again, a reminder, Council, to please use your Zoom hands for voting, for questions, and for comments. That'll make my keeping the speakers list an easier task. And at this point in time, I would like to turn to our official opening of the meeting by reading out our land acknowledgement. The RCDSO is on the traditional lands of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. These traditional lands are known to some as Toronto. Toronto is covered by Treaty 13 with the Mississaugas of the Credit and is home to many diverse First Nations, Inuit, and Métis people from across Turtle Island. This land is also part of the Dish with One Spoon territory, a treaty between allied nations to peaceably share and care for this land. We accept our responsibility to each other and this land we live and work on in a spirit of peace, friendship, and respect. We are committed to actively supporting the necessary work towards truth, reconciliation, and equity. We embrace the role we play in regulating dentists, in protecting the public interest, and in strengthening our partnerships with Indigenous communities to advance access to safe and equitable oral health care. Thank you. And at this point, I would like to turn to you, Dan, for our roll call, please.
Thank you, Hanno. And council members, I will be going in alphabetical order, so just be prepared to unmute. Starting with Nalan Bargava.
Present.
David Bishop. Okay, I don't think David's arrived yet. Amelia Chan.
Present.
Ram Chopra.
Present.
Jamie Colliver. Is Jamie still having trouble with audio?
Yes, unfortunately, we're still trying to support
Jamie is
currently.
here, though. We'll note he's here. Christina Cordero.
Present.
Peter Delane.
Present.
Nancy DeSanto.
Present.
Ellie Fisher.
Present.
Noha Goma.
Present.
Daniel Haas.
Present.
Vivian Hu.
Present.
Nizar Ladak.
Present.
Anthony Lischio.
Present.
Anthony Mayer.
Present.
Harinder Sandhu.
Present.
Brian Smith.
Present.
Osama Solomon.
Present.
Robin Somerville.
Present.
Rod Stapleforth.
Present.
Mark Trudell.
Present.
Aaron Walker.
Present.
Judy Welikovich.
Present.
And Deborah Wilson.
Present.
Thank you, Hanno.
Thank you. And now I would like to turn it over to Harinder for his president's report.
Thank you, Hanno, and good morning, everyone. One of the themes today's council meeting is education. Lifelong learning is required for the profession, and it is crucial for council too. It helps us keep up with contemporary research and thinking. It helps us be better at all that we do. Today, we'll be hearing from Rainbow Health Ontario. Their mission is to help healthcare professionals better understand the 2SL LGBTQ+ community. Rainbow Health has an excellent online learning platform that offers CE credit for many professions, including dentistry. It is so important for those of us in the profession to have a deeper understanding of our patients. It helps us become better dentists. We will also hear about research underway under the strategic plan. Practice models and corporate dentistry is evolving rapidly in our profession. Understanding the scope and context of the business model is so important to regulation. Modern regulation must keep pace with the development in practice. As you will hear later, They're both issues and opportunities in new practice models, and council will benefit from this knowledge. We'll also be hearing about an organization called Choosing Wisely. They are a cross-disciplinary group focused on reducing unnecessary tests and treatments. Their work is research and data informed. Their goal is to reduce patient harm as well as the demand on precious health resources. Unnecessary tests and treatments can also have a significant environmental impact. This is a key issue for many dentists who are keen to reduce their impact wherever possible. We don't do this work alone. Our partnerships with organizations like Rainbow Health and Choosing Wise open opportunities for us to grow. We learn from others, we expand our expertise, we offer more to the public and to the profession. And speaking of not working alone, all of you in this virtual room contribute to work of regulation. Thank you for helping to keep Ontario patients safer. And on that note, I would like to speak about two council members. I would like to take a moment to acknowledge the reappointment of public member Vivian Hu. Vivian, who's a former public health inspector and public health educator, serves on the ICRC committee. She's also chair of the Patient Relations Committee. Thank you, Vivian, for all that you do for the college. Congratulations. We look forward to work with you over the next 2 years.
Thank you for your kind work, Dorinda. Looking forward to working with everyone.
Thank you.
Thank you.
I would also like to let you know about a departure from our ranks. Dr. Mark Eckler has stepped away from council and all his college-related roles effective October 11th. He wanted you to know that his time has been very rewarding to him, both personally and professionally. Dr. Eckler's time on council was ending in the next couple of months as he has served the maximum allowable time. He has decided to leave early to pursue other opportunities. It has been a great pleasure for me to serve alongside Mark. He brought knowledge, expertise, and a keen interest to every conversation. His engagement, his good questions, his considered comments were so helpful to committees, council, and the college. Mark served as chair of the Finance, Audit, and Risk Committee, and as a member of the Pension Committee and the Procurement Review Group for the PLP divestment. We will address the vacancy later in this meeting. To close, I would like to thank all of those who helped prepare this meeting. Your role is so important to council. We could not have good discussion or good decisions without your support. Dan, I personally appreciate all the support you provide. Your senior leadership team and the entire staff of RCDSO make our work easier. More importantly, your focus on the patients of Ontario is commendable. Council, I'm very happy to be working with you today. Your insights and advice improve every conversation. To all of those who are joining us via YouTube, thank you so much for your time and attention today. Many of our observations are in the field of regulation, and we are glad to have you here. With that, Hannah, I'll turn it back to you. Thank you.
Thank you, Harinder. Next on the agenda, Council, is Declaration of Conflict of Interest. And the Declaration of Conflicts is a standard that is captured in the Ministry of Health College Performance Measurement Framework. And just a reminder, the college is working with PricewaterhouseCoopers on the PLP divestment project, and there will be a short update on that today. So at this point in time, I'm going to take a moment to ask if any members of council feel they have a conflict of interest, real or perceived, to declare for any of the agenda items to be discussed today. And seeing none, I'm going to move on to the next item on the agenda, which is our consent agenda, which falls under the category of governance best practice. We do use a consent agenda as a time-saving mechanism. On the consent agenda are several items for council's information, acceptance, and ratification. I will be asking you to approve these in one single motion. You can, of course, ask questions of clarification. However, if there is a further or deeper conversation, I would ask that that item be removed from the consent agenda, and we will deal with that later on in the meeting. I would just like to remind you that that threshold is very high, so please consider that before asking to have any item removed from the consent agenda. Are there any questions or changes to the consent agenda? Seeing none, could I have motion number 1 on the screen, please? And motion number 1 is that the following items be approved and or received for information by council. Approval of agenda, approval of RCDSO council meeting minutes, September 20th, 2024 with appendices, council evaluation survey results, September 20th, 2024, RCDSO council work plan, 2024 council education plan, OPSTD pilot project, financial update, public member reappointment. That's moved by Anthony Lisho, seconded by Vivian Hu, and I would ask you all to use your virtual hands to raise that. So I see 19 in favor. Please lower your hand. Are there any opposed? Any abstentions? Okay, well, that did pass, even though according, unless I saw a glitch, I didn't see it pass unanimously, but it did pass. So thank you for that. Next, we're going to move on to our presentation for this morning. We do have a special presentation. Rainbow Health Ontario creates opportunities for the healthcare system to better serve 2 SLGBTQ+ communities. And as you may know, in September of this year, the Quality Assurance Committee approved Rainbow Health Ontario as a sponsor for continuing education. Michelle Tremblay, Organizational Transformation and College Equity Officer, will now introduce our guest. So Michelle, I'm going to turn it over to you now, please.
To make them useful, we want you to build your skills and we want you to bring your questions, right? So we get into, this is why we have facilitator-led trainings, because we want the discussion to happen. We want people to come to us and really say, I don't know how to do this, or I feel overwhelmed, or I have this situation that is tough at work. I want to do this, but this other person doesn't want to do it. So we unpack as much as we can.
Thank you. Thank you.
Thank you, Council, and thank you again, Sil, for taking the time to come and address us and help Council in its education journey. So we do appreciate the time that you've taken to come and speak to us. So thank you.
Thank you for having me. I really appreciate it.
Have a wonderful day.
Bye.
Next on the agenda, Council, is an update on the Professional Liability Program Divestment Project. At both our June and September meetings, Council received an update on the divestment process. This item is for your information, and material can be found on pages 251 to 252 of your Council package, and I'm going to have turn it over to Dan now to address that.
Thank you, Hanno. And Council, as you heard at the September meeting, there's not a lot of new information that I can report today, but there are a couple of higher level or general process type issues that I just want to emphasize or re-emphasize. First, I wanted to just share that there has been a lot of activity. There are a number of conversations that are happening with our advisors, PwC, and entities that are interested in hearing more about the PLP area and the program. And there are a number of non-disclosure agreements that have been signed so that we're able to share more detailed information. And we are looking forward to seeing expressions of interest from a few of those organizations sometime within the next month or so. So there's still going to be a lot of work happening between now and the end of the year. But we're quite hopeful that we will see some EOIs that will be reviewed by our procurement review group sometime before the holiday season. I also wanted to just acknowledge, and Harinder mentioned this earlier, that Mark Eckler, in his departure, he's left a spot on the PRG, the Procurement Review Group. So there's work going on right now to consider what we will do with that spot. And the executive committee, while it was scheduled to meet on November 1st, I know we've had some rescheduling that we've had to do, and it's not quite landed yet. But the executive committee will consider that particular spot on PRG and report back to council at the December meeting. And finally, there are a number of considerations that we have with respect to how to ensure that all members of the profession carry professional liability insurance, and that will take the form of bylaws and regulation amendments. So there's a lot of work that's happened on both of those. You will see some proposals for amendments at the December meeting. And we've also been working with the ministry to ensure that when we get to the point of having a proposed set of regulation amendments, then we will be able to hopefully move quite swiftly through the consultations that are required and all the other work that's required between the college and the ministry to get those approved. And essentially what they will do is allow for the college to be able to take action in the event that a dentist does not carry professional liability insurance, and also to allow the individual to be reinstated quickly when they are able to demonstrate that they have insurance. So again, you will see all of that with a much more complete explanation in December. So those are the highlights that I wanted to just provide to you. And again, a lot of the information, as I've said before, is sensitive, so we won't necessarily talk about it in this public meeting. But if you have any general or process or high-level comments or questions, happy to consider those.
Thank you, Dan. And I'm not seeing any hands up. So the next item on the agenda, I'm going to turn it back over to you again, Dan, is the Registrar and CEO's report. And it's back to you, Dan, please.
Thanks, Hanno. And I have a slide deck that's just coming up. Thank you, Angelo. This is a little bit of a shorter report. We're not at one of our quarterly meetings. So as you noticed, I didn't provide a written report. I try to do that 4 times a year. I'll just give you a general update of some things that have been happening around the college since our last meeting in September. First slide. So I've started with the Canadian Dental Care Plan, CDCP, because obviously that is a topic that is still at a high priority list for many. The utilization statistics or data is presented now to the public through a Health Canada webpage. You can see that the number of patients is over 750,000 that have received care where there has been a claim made to CDCP or to Sun Life. There are 18,250 dentists as of September 19th that have made at least one claim on CDCP, and just over 8,000 of those dentists are in Ontario. In December, I'll be able to provide you a little bit more of a comparison as to how the numbers are moving up, but I just wanted you to just have in front of you where we are with respect to that program and the participation rate that we're seeing at this point. There are a couple of large-scale ad campaigns that are happening, one through Health Canada, one through the ODA, and they are really looking to provide information to the public specifically about the program to ensure that accurate information is available and understood. And I've put under emerging issues that we received a response back from the Federal Minister of Health. The President and I sent a letter back in April. This was provided to you in additional materials that went out earlier this week, I think, that were the letter that we sent and the response back. And essentially, we focused on a couple of issues, including the way in which at the time in April, the Health Canada was going to have contracts with individual dentists and then change that to allow for claims submissions without contracts. We also looked at the need for more coordination between CDCP and provincial programs, and there's certainly been some work that's happened in that area. And the final point we made was to indicate our support to be involved in discussions about developing any of the compliance on-site audit procedures. I have heard recently that Health Canada would like to start some discussions with us in the, I would say, winter, spring, because around the March or April time period. So we will certainly be involved to help them to design a process and to determine at that point what role that RCDSO will play in that, and obviously considering what sort of resource impact that might have, which at this point I couldn't begin to answer that question. So just some brief updates on CDCP. Next slide. I'll talk a little bit about a couple of things happening on the landscape. First, I've mentioned before that the Ontario College of Pharmacists is exploring various solutions to practices and corporation practices that are, in a sense, minimizing or eliminating patient choices or impeding on professional clinical judgment. And one of the responses by the government of Ontario is to do a consultation on preferred provider networks. And this is when employer-sponsored drug insurance programs ensure that the dispensing of pharmaceuticals are done through a particular pharmacy, so the preferred provider network. That clearly has an impact on patient choice, and the government of Ontario is trying to understand this better and to also determine whether there are policy or legislative solutions that are needed. In response to the consultation, we provided a response back, a letter, a short letter, but we wanted to signal that the issue of corporate influences goes beyond pharmacies. So we didn't provide solutions, we didn't provide recommendations, but we wanted the government to know that in any solutions that it might develop, that there are examples in other professions where this does occur. So we certainly want to be involved and engaged in any of those solutions as we move forward. But we are at a very early stage with respect to any possible legislation, if that comes. But certainly we will keep you informed and involved in any submissions that we make that are more detail-oriented. Next slide. I wanted to point out as well that the College of Nurses of Ontario recently did a workforce census, and what they did was they gathered information, demographic information, how individuals identify from the 200,000 plus nurses. The response rate was about 31,000 participants. There are reports that have been available, and I can certainly make them available to you. I know there are some webinars coming up. It was a very, I think, a very interesting and timely approach to really understanding who makes up the workforce in nursing, and then starting to think about some of the barriers that might be a part of that profession that might relate to diversity or inequities. They explored a number of different questions, and I've only listed a few here, including Indigenous identity, ethnicity, race, disabilities. So lots of different ways to truly understand the profession. And they're going to look at that, obviously, to think about baselines. They will likely replicate this survey as we move forward into the future. And I am more than happy, maybe as an information at the next meeting, to provide materials and links that give you a little bit more information, but it is fairly hot off the press within the last 2 or 3 weeks. And as I said, there will be some webinars coming up to learn a little bit more about what their findings were. Next slide. In terms of a report that came out, and I've put this under the partners and collaborators section, I think it's relevant to some degree for colleges or regulatory bodies, but Statistics Canada just released a report, it was earlier this week or late last week, and looked at the economic impact of COVID on the Canadian dental industry. And I've pulled out a couple of findings, and there are many others, and you can certainly take a look at that. It is online through Statistics Canada. We obviously know that there were some pretty major disruptions in the dental economy during the time of COVID, that the economic impact, as you can see, was a $3 or $2.5 billion reduction between 2019 and 2020. They do report that recovery has been strong, and in fact, where we sat in 2022 and in 2023, is exceeding the total number of jobs and the economic output from the pre-pandemic time in 2019. So I think it's interesting for us to just be aware of some of the things that impact dental practice and have maybe a more distal impact on regulation. But that report, as I said, is available if you want to give it a read. I also wanted to comment, as you know, nationally, the dental regulators and their federation approved dental anesthesia as a specialty. And that was last year, or I think early to mid 2023. And there is work underway now to start to develop dental anesthesia standards that would be available as part of accreditation programs and training programs that would be utilized by training programs across the country. Not every province has adopted yet dental anesthesia as a specialty, and some of that is related to the legislation or the regulation that they have within their jurisdictions. But obviously, as you know, dental anesthesia has been recognized in Ontario for a number of years. So we are certainly not as impacted by this. We don't have a lot of work to do, but we're obviously going to provide any comments on the dental anesthesia standards, which we've done some of that to date, and there'll be more opportunity to see the standards as we move forward. And likely they would go through our Quality Assurance Committee. In terms of the national accreditation body with the acronym CDAC, they've also developed a new strategic plan. And a couple of areas of note that I've talked to this council about, and I think I've mentioned it within the last few meetings as well, is they are still going to be focusing on things like transparency of accreditation reports for training programs, and also looking at how their funding is structured and what role regulators should play in that. And is there a different formula that can support the national body, where right now regulators in dentistry, dental hygiene, and dental assistants pay probably 75% of their annual operating budget. So there's certainly a room to look at that and to determine what that formula needs to look like going forward. I know you received an email recently that training is available. We are, organizations are under obligations to ensure that training occurs around accessibility for Ontarians with disabilities. We are looking now to augment the fact that 100% of staff are trained, and as new staff are onboarded, that training is automatically available. And all council and committee members now will have to do this training. So we've set November 30th as a completion date. If you haven't seen that email, please take a look. Please plan for doing it. I don't have all the details. I think they're fairly short modules, but if there's any questions or concerns that you have, Megan from our Human Resources Department sent the email or is available for conversation with you. But we really have to have 100% completion rate because this is a legislative responsibility. I just wanted to comment that our leadership team had a full-day meeting on September 26th. We try to do at least one full-day meeting a year. This is our commitment to leadership, learning together, really trying to map out what we want the organization to look like and feel like as we all dedicate a lot of time to the organization. And this year we talked about a number of topics that related to resilience and leadership, change that obviously happens in the environment quite rapidly, and applying equity, diversity, and inclusion learning and principles to real life situations that we all experience every day. So lots of commitment by our broad leadership team, which includes the senior leaders that you see often at the council meetings, but also all of our directors and managers who are doing an incredible job to keep this organization moving forward. Next slide. Very quickly, I hope you received your RCDSO Connect newsletter. It went out a few weeks ago. It's packed with information on lots of different initiatives and information that we think that our partners should know about. And that includes obviously dentists, but it also includes public who have subscribed to the newsletter, stakeholder partners like associations and education and training bodies and national bodies. So we're really, there's been a lot of work to really bolster the kind of information that's available and making sure that the principle or the value of transparency is lived in all sorts of different ways, and the newsletter is just one way to do that. I also want to point out that we have a couple of new infographics online that are really interesting, have received a great response so far from various partners, and we try to distribute this in a number of different ways, including our own social media vehicles for this. On the left is something we worked on with the association that was trying to address a lot of the confusion that exists out there about what's the RCDSO do and what's the ODA do. And they are really distinct roles. And there's, and I say we often, we will have agreement on a lot of issues, but on some we won't. And it's really important for the profession and the public to understand what those roles are. So hopefully you get an opportunity to take a look at that, and we can provide links if you aren't able to locate it. And on the right is, I think, a very timely infographic that relates to social media. And we want to make sure that the profession is using social media responsibly, particularly as it's linked back to their identity as a professional. So pause, think, post is really some helpful advice in terms of thinking about social media, as many dentists are very active. And thinking about a lot of the things that can pose some difficulty for members of the profession, and hopefully this can be in some ways risk management for them. So pretty accessible document in terms of some information that's really helpful on a one-pager that's available on our website. And as I said, we're also trying to send that around through our own social media accounts as well. And finally, I just wanted to, I mentioned before, but we had our CNAR is a national regulatory organization. It had its annual meeting in early October. The meeting itself is attended by close to 1,000 people. It is quite a big regulatory event. It has all the topics that you can imagine that are current and related to regulation and the challenges and the opportunities that we all think about every single day. It's not just health regulators, it's non-health regulators, and it's sector-based regulators. And you can see that we had a plenary session where we talked about access to care and access to justice. And you can see Andrea Foti and Michelle Cabrera-Gali from our policy area were on the panel. And we had two of our colleagues from the Law Society of Ontario who were talking about access to justice and initiatives that they were involved in. And I had the pleasure of moderating the session. It was very well received, a lot of interest. We had lots of conversations afterwards. And I just wanted to really describe to you that a lot of the work that we're doing here at RCDSO is being very well received by regulators across the country. And that's all I have for today. I think the next slide is just a question slide, and we can stop sharing, and I'm happy to entertain any questions or comments that you have. Thank you. Back to you, Hanno.
Thank you, Dan. So at this point in time, I will look to council to see if there are any questions you would like to ask of Dan. Nizar.
Thank you, Hanno. Dan, I had both a question and a comment. My comment was in the particular slide you shared with the two infographics. I had come upon them in my review of the site, and I have to congratulate the team. I thought they were absolutely fantastic, and they were particularly relevant because of my involvement in our incident reporting committee, where there has been a lot of questions asked about what's an appropriate marketing mechanism for the dental profession, respecting their clinical sides and other things, but also acknowledging they are independent business practitioners. So I really found the slide about pause and think enormously helpful. So again, my congratulations to the team. But my question was, are we hoping to do more of that? Because I think this would be enormously helpful to the profession.
Thank you, Nizar, and kudos to Leslie Byrne and the communications team. And I would say the short answer to your question is yes. I mean, I think the way in which Leslie and the team are approaching information transfer and knowledge transfer is in real digestible chunks, real accessible information. The one-pagers are always great to provide a lot of good information. And we're also We have done and will continue to do infographics with metrics. So yes, Leslie may want to kick into the conversation as well. We can go on to Nancy's question, and Leslie, maybe you can just tee up if you want to add some additional comments to that as well.
No, I just want to say thank you so much, Nazar, and thank you to some of you who've reached out to congratulate us. They're a ton of work because lots of people have input into them, and the suggestion box is always open. We're really interested in providing information that's practical, and just like we heard from Sil earlier today, like what's going to be useful, we want to do it and we want to provide it. So thank you very much.
Thank you. Nancy.
Thank you, Hanno. Dan, I always enjoy hearing your reports. They're so informative. I really wanted to make a comment basically on the new infographics. I think they're excellent. And I was wondering if there would be a consideration made to send them via an email blast to members of the profession as like a little bite. I just think they're just so excellent. And Leslie, congrats to you and the communications team. Fantastic. Thank you.
Yeah, thanks, Nancy. And we're looking at all sorts of ways to get the material and information to the profession. And an e-blast is certainly one way, and through the newsletter and others. And Leslie's heard that. I see her nodding. So thank you for the suggestion.
Thank you. Any other questions for Dan? Okay, seeing none. Thank you, Dan. Thank you, Leslie, and thank you, Council. We are way ahead of schedule. So what I'm going to propose, and I'm going to speak very slowly to give Jeffrey a heads up. The items after our break, some of them are a little bit more lengthy, but I would propose we move to item number 10, which should really only be about a 5 or a 10-minute item, and then we can break. So item number 10 is on Pension Governance Committee restructure. So Council, I'm going to give you a second to find that in your agenda and hopefully not take Jeffrey by unawares. This item concerns an important update to the college's approach to governing the employee pension plan. The materials for this item are on pages 288 to 291 of your meeting package, and this is an item for Council's decision. So Jeffrey Goldberg, CFO, is here to lead us through the material. And I'm going to turn it over to you now, please, Jeffrey.
Thank you for speaking slowly, Hannah. So I'm raring to go. So the material is on, I think, slide 289. There's a BN there, and the recommendation of the BN is really to restructure the Pension Governance Committee. So instead of a committee of council, it would be a staff-led committee. So the current committee was formed in 2018. And at that time, the plan contained several risks and high complexity really due to the defined benefit or DB component of the plan. So the committee during their time implemented a number of strategies to de-risk the pension, with the final strategy to annuitize the DB portion of the plan, which is essentially selling the assets and liability of the DB portion. So that annuity process will be complete next year in 2025, and we will be left with, at that time, the DC, or defined contribution plan, to manage, which has far less complexity and risks associated with it. So we did a bit of a scan, and most regulators do not have a separate pension committee. Most of them folded into their finance committees. But we do see several benefits in implementing a staff-driven committee. So the recommendations are described in the BN, and membership will include staff who are actively managing benefits and the plan. And we will have 2 elected staff representatives as well. So this is a similar model as what CPSO has, who we interviewed, and they find this to be quite effective in managing their pension plan. And I think the staff who are elected really appreciate being on that plan. There will still be appropriate oversight from the committee, our pension consultants, and there will be a member of FAR who will sit on the committee. And large decisions that are significant would go up to FAR as well. So we'll also have the plan reviewed by our auditors, and we have to report to FSRA, who is the regulator for pension plans in Ontario. So there's a number of checks and balances for the plan. So this change does require an amendment to the bylaws, and those are detailed in the BN and essentially relate to removing references to the Pension Governance Committee. It will no longer be a committee of council. So those are my brief comments, but I'll turn it back to Hannah now.
Thank you, Jeffrey. And any questions for Jeffrey before we entertain that motion? Nalan.
Yeah, just thanks, Jeffrey, for that update. One quick question. Do we have a date? What is the date when we'll have 100% defined contribution and 0% defined benefits for our RCDSO employees?
Well, the plan will be frozen effective December 30th or 31st this year. Moving to the buyout annuity, we're currently in the buy-in, as you probably know, will be determined. It'll probably be by Q2 next year. But right now, IA, Industrial Alliance, has all the assets and they make all the payments to the pension. So it's just finalizing the final piece to that, which we'll do next year.
Okay, thank you.
Thank you. Judy?
Yes, thank you, Hannah, and thank you, Jeff. It's an interesting thing that's going on here, and I'm not sure I understand why the council would be comfortable not having this committee basically accountable to the council, because it seems to me that management of the pension or governance of the pension is a big responsibility, and if the pension were to somehow be inadequate, then it's the council, speaking for the corporation, that bears the responsibility for that. So if you can explain the thinking behind removing the council. I realize there's going to be a FAR member on there, but that's not the same thing. So if you could explain that, I would be most grateful. Thank you.
Sure, and I will turn it over to Jamie as well, who's the chair of the pension committee. You can describe this, but I'll start, and maybe Jamie can take it over from there. So by removing the defined benefit portion of the plan, we have taken almost all the risk out of the plan. And we've taken complexity out, and we will have a bit of a reporting remaining, but most of that will be gone. The only plan we have now is where staff contribute 5 to 8%, and the college manages that. So that is run through payroll. So there's really no liability that the college will have to make up. Jamie, I'm going to ask you to add a few comments to that, if you don't mind.
Oh, sure. Thank you, Jeff. And thank you, Judy, for your question. The whole idea of doing what's being suggested here is, as Jeff said, removing risk to the college. So in doing so, you're actually adjusting the risk to the employee. Essentially, defined contribution is just that. So understanding that there is more risk to the employee, I was very comfortable, and I think the committee was very comfortable with the providers that we have for the defined contribution plan and our consultants to educate and keep abreast of all market activities that the employees will want to hear. And therefore, an employee-driven committee will be
very attuned to investment performance and all aspects of their pension plan. So it totally takes off the table the risk to the college as specified, but at the same time, it gives the employees options for understanding their future payments, understanding their investment positions and therefore risks. So we are just conforming to basically what's happening out there in the world. Essentially, defined benefit plans would be legacy plans. The only significant defined benefit plans out there are the major pension plans in Ontario, for example, the Big Five. So this is not a radical move, and I don't believe the council needs to. And I don't believe it needs to be a committee of the council. So I fully support this move, and it's totally about de-risking to the organization. Does that help?
Thank you, Jim.
It helps to the extent that, I understand the difference between defined benefit and defined contribution plans, but I mean, there isn't zero risk. And I'm very cautious about these things. And so I probably would be more comfortable with a council representative, not just the FAR representative on the committee. I'm not sure I understand why council needs to be removed. I'm not saying I don't support the type of composition you're talking about in terms of elected staff. I think that's a really good idea, but ultimately for me, it's about governance and making sure that the plan is overseen in an objective way. And I understand that basically, defined benefit plans, defined contribution plans are basically self-directed RSPs under the big umbrella. But nevertheless, I mean, I can't come up with an example, but it's not sitting well with me. I have this nagging sense that, it should be something that council is at least participating in.
Well, maybe, Hanno, I can jump in. So all the members of FAR except for one are council members. So we can make sure that there is the FAR representative. Typically it will be the chair, but we can make sure that is a council member. So there is representation for council and FAR committee.
Okay, as I said, for me, I look at it, I think, slightly differently, but I take your point, and I'll give it some thought as we consider the motion.
Thank you. Peter.
Thank you, Hannah. Question I had for Jeff was, I'm wondering, Jeff, if there are any associated costs between now and when these changes officially take place. Do you anticipate any cost to the college over the next few months?
The only costs we would experience that I foresee in the next couple of months are when the defined benefit annuity is finalized. We'll have some costs to update the plan text, which is the fundamental document that describes the plan and is submitted to FSRA. So there would just be some consulting costs associated with that, but our costs generally will be much reduced from prior years. And we will no longer require an audit.
Thank you, Jeff.
Robin?
Hi, thank you everybody for the presentation. I'll just be quick. I think Judy stated my concerns and I just wanted to reiterate that I share the same concerns as her. Thanks.
Thank you, Robin. There are no other speakers on my list, so what I would ask now, if we could please see motion number 2 on the screen. And motion number 2 for your consideration, Council, is that effective January 23rd, 2025, Council revokes bylaw 4.16, Pension Governance Committee, and amend Article 5.2.5, Standing Committees, to revoke paragraph 1, reference to Pension Governance Committee. And Council, since this is a bylaw change, this would require a 2/3 majority. I see it is moved by Jamie, seconded by Christina. So I would ask you, all those in favor, to raise your virtual hand and keep it up there until I ask you to lower it. And Angie and I will do the count because we do need a 2/3 majority. So Angie, I'm seeing 20 in favor. Do you agree with that?
I see 20.
Okay, thank you. That then does carry, but I would ask that everyone to lower their hands. If you are opposing the motion, raise your hand, please. And okay, 1 opposition and then 2 oppositions, thank you. You may lower your hand. And that motion is carried. So thank you, Jeff, and thank you, Council. At this point in time, Daniel Haas.
Yes, I'm just wondering if there can be a follow-up, either some note mentioned to get to Judy's point about ensuring that the FAR member is a council member that will allow the opportunity to report back to council if there are any issues of concerns. Because if I understand it correctly, that is Judy and Robin's concern. So could that be minuted somehow, or some direction taken that would become the way it goes forward?
I'm seeing a few nods, so I'm thinking that your point is well taken, Daniel. Thank you for that. At this point in time, I'm going to suggest we do a break now until 10:25, when we will return. So I would ask that you turn off your microphones as well as your cameras, Council, and we will see you back here at 10:25. Thank you very much. Thank you and welcome back. The next item is designed to provide an overview of college progress on the strategic plan. This item concerns practice models and corporate dentistry, one of the 6 strategic projects currently underway. Ontario dentists practice in different practice models, and these have traditionally included private dental practices and multiple offices owned and operated by a single dentist or multiple dentists. The goal of this project is to research practice and regulatory models. With your guidance, Council, this work will help inform the modernization of oral healthcare regulation to enable effective regulation of a variety of practice models. The material in your package can be found from pages 253 to 287. This item is for Council's information and discussion. Denny Ogurindi, policy analyst, will walk Council through this material and facilitate a short discussion. And Denny, I'm going to turn it over to you, please.
Okay, great. Thank you, Hanno. Before I get started, can you see my screen without any kind of black boxes covering the material?
Yes, we can.
Great, thank you. So I'll get right into the agenda for starters. So today's session is two parts. The first part will be a roughly 35-minute presentation concerning background on the strategic project with a real focus on highlights from the research that's been shared with you, both as part of this council materials package and part of the package in September. This last 25 minutes of this session will be an open discussion. There will be an opportunity for you to ask questions about the materials that have been shared with you, but we really want to spend the bulk of that time kind of getting your thoughts and your perspectives on the materials that we've shared. So for background, Practice Models in Corporate Dentistry is a strategic project under the 2023-25 strategic plan. The objectives are really threefold: to better understand dental practice models in Ontario, to identify the issues and opportunities related to various practice models, including for corporate dentistry, and to develop options to promote and assure quality of care, and to ensure effective regulation of dentists regardless of the practice model type. And this is really the core focus of this work. Now, this work is taking place in three phases. The first is, or has been, mostly information gathering. So doing things like desktop research to do a jurisdictional review, a literature review, holding the consultation that we held earlier this year on this topic to get feedback from registrants, patients, and other interested parties. Phase two involves analyzing that data so that we can better understand what are the core issues related to different practice models or across all practice models, and also opportunities. This phase also involved looking internally at college data that we have available to see where we could gather a bit more information on this topic. And then finally will be phase three. So this is where we'll be looking to you. We'll be sharing options and recommendations to address the issues and opportunities that we've identified, looking to get your feedback on those as a first step. And then as a second step, looking for approval to move forward. After that point, we'll be developing an implementation plan to execute on that direction. So including things like timelines, pace, and operational considerations for implementing those approved recommendations. Currently, we're here, so I'm going to be providing you with an overview of the research that's been conducted and shared with you to date to kind of prep you for future decision making. I'll be starting with highlights from the literature review. So this is actually in the September Council Materials package. If you go to page 256 in your current package and click the link to the September Council Materials, it's page 142 in those materials that you will find this literature review summary. So what were the objectives of this work? Well, there were a few. We reviewed academic studies and gray literature, so things like government reports and media, to better understand the issues and opportunities related to emerging practice models, specifically for patients. We also looked at other factors that might impact care provided across models, and then any approaches that came up through this research to help mitigate some of the issues. But the core focus was really the issues and opportunities, so I'm going to be focusing on that today. So the main suggested issues or risks related to corporate dentistry for patients relate to a loss of clinical and non-clinical autonomy in registrants' practice, as well as profit-driven conflicts of interest. And when I refer to profit-driven conflicts of interest, I'm considering both those on the revenue generation side as well as the cost efficiency side. A couple of studies really kind of captured some of these issues quite well. There was a qualitative study, so it was an interview-based study of dental associates in the United Kingdom, those that work both in corporate and non-corporate environments. And this study demonstrated a clear disparity, so among the registrants that participated, between corporate and non-corporate environments. Associates that had experience in both sectors acknowledged that the non-corporate environment generally offered a greater level of freedom than the corporate environments in relation to both clinical and non-clinical decisions that they were able to make. So things like choosing the types of materials and labs that they could use, and in some cases, the referrals that could be made. A second study, very similarly done, so it interviewed registrants or dentists that work in both corporate and non-corporate models presented a little bit more of a balanced picture. So they found that in both independently owned and corporate dental practices, so some registrants were found, so the owners were found to set targets and use targets as a way to measure productivity. And there was also an appreciation among those interviewed for the fact that, dentistry ultimately in most cases is a business. It's not publicly funded broadly. So profit is going to be an important consideration for most of the clinics that exist, whether they are independent or corporately owned. Now, what are the impacts of these kinds of issues for patients? Well, in some cases, there have been examples where these types of issues and risks have led to poor quality of care for patients. So things like overtreatment, providing unnecessary treatments, poor quality preventative and therapeutic treatments. And these result also in a financial loss for patients. So particularly if the care that's provided is unnecessary, in addition to potential insurance and government support program fraud, if registrants are making claims for procedures that were never provided, or they're suggesting that a procedure was more complicated and more costly than it actually was. Some of the bigger examples that you find concerning corporate dentistry are really in the United States. So I've pulled a couple of those examples here for you. The first example that I have relates to Aspen Dental. So this is a dental service organization, a company that provides business and administrative support to I think over 1,000 clinics in the United States. The New York Attorney General's office began investigating the company in 2013 after they had received about 300 complaints. Through the investigation, they found that the DSO was incentivizing via bonuses and pressuring staff to sell dental services and products. They had implemented revenue-focused scheduling systems, and they were also pressuring patients into having consultations with non-dentists, so office managers, who were trained to support patients in making treatment decisions. In 2015, the company did reach a settlement with the New York State Attorney General's office. So there was a fine they had to pay, and they were also required to do a few different things. They were required to reform their business so that they did not dictate or communicate with clinical staff regarding the care that they provide to patients. They were ordered to no longer split fees with dental clinics. That was something that was happening. And they had to be clear in marketing materials that only administrative and business services are provided by the company. In the second example here, it relates a little bit more to the provision of care through government funded programs. So the U.S. Department of Justice had alleged that the private equity owner of the company Benevis, so Benevis is the dental service organization, it was alleged that the private equity company was routinely pressuring and incentivizing dentists at the clinics that were owned by Benevis to meet production goals. The Department of Justice also alleged that the clinics billed around 17 different state Medicaid programs for fraudulent activities that took place at over 130 clinics, which are called Cool Smiles dental clinics. These include unnecessary tooth extractions and root canals on children and babies, and then subsequently billing for things like root canals where they were never performed. Switching gears a little bit to direct-to-consumer dentistry, the suggested issue and risks related to this particular model for patients are generally poor treatment outcomes and damage to patients' oral health as a result of not having a comprehensive exam prior to beginning treatment or having oversight over the course of a treatment by a dentist. There was one study that was done in the United States that I found particularly interesting. So a group of researchers looked at the adverse event outcomes that were reported to the U.S. Food and Drug Administration, so the entity that regulates medical devices in the U.S. And these reports were made by dentists, patients, or others associated specifically with direct-to-consumer dentistry where there was no involvement from a dentist. There were only 104 cases that they ended up reviewing that met this criteria. But I found that this graph to be a really helpful representation of the types of adverse outcomes that can happen for patients. Bite problems were the most commonly reported, followed by orofacial pain and this miscellaneous category at the bottom here, which refers to things like cavities and tooth loss. So it's clear that there are adverse outcomes that have been at least self-reported by patients or reported by dentists in relation to this model. Switching gears again, there are also benefits associated with these models that we found in the research. So suggested benefits of corporate dentistry for patients include, as a result of business and administrative support, greater focus or exclusive focus by the registrants on the provision of clinical care. I wasn't able to find studies that quantified, this increase in focus or the impact that increase in focus might have on patients, but it's something that's suggested quite a lot, both in government reports and in media. The other thing that is a benefit here relates to the fact that there tend to be lower business costs that can be achieved through economies of scale within a dental service organization in their network. And as a result, there can be greater access to care for patients in a few different ways. One is that the savings through the cost efficiencies that are achieved could be flowed through to patients so they can have lower costs for their care. There can be more patients that can be treated in some of these models, or it's something that's been suggested as a result of those clinics being able to accommodate or withstand lower revenues that they receive, so they can accept more patients from government funded programs. And there's actually a study that came out in 2020 from the Health Policy Institute of the American Dental Association that kind of supported this. So around 43% of US dentists at this time participated in Medicaid or CHIP, which is the Children's Health Insurance Program. It provides dental services for children in the United States. And when they looked at dentist participation by the type of organization that they worked in, they found about 63% were affiliated with DSOs, which is quite an overrepresentation when that's compared to the amount of dentists that are considered to be affiliated with DSOs in the United States. The final point here is that there's also been the suggestion that more clinics may be to be established in underserved areas where costs may be lower, but you also may be likely to have lower revenues coming into the clinic because there's less patients around. So there's a few different benefits that are suggested here. For direct-to-consumer dentistry, there are similar benefits that are also proposed. Greater access to care is proposed as a result of direct-to-consumer aligner treatment being more affordable for patients compared to in-office aligner treatment or in-office braces treatment. And also just greater convenience, not only for those who don't live near a dentist or they live near a dentist, but the dentist doesn't provide orthodontic treatment, but for those who have disabilities or other health considerations that might make it more challenging for them to go in person on a regular basis to see a dentist. There was one study that was done in 2020 that actually surveyed about, I think it was 450 or 60 patients who either had started, were in the middle of, or had completed direct-to-consumer aligner treatment. And the aim of the survey was to better understand users' experiences with at-home aligners. And they found that almost in every case, the patients indicated that the top reason for choosing at-home aligners via an in-office treatment with a dental provider was cost. The second most commonly cited benefit for them was convenience. So these are things that not only we're seeing in literature as being supposed benefits, but when patients are commenting on their experience, they're saying that these are their perceived benefits in these models. The only other thing I'd like to point out from this study is that they also looked at the satisfaction rate of patients that had undergone direct-to-consumer aligner treatment, and they found that most were either satisfied or very satisfied with their treatment. I will note that in this particular case, there were some patients who were, most of the patients were Smile Direct Club patients, and there was a subset of those that had signed non-disclosure agreements. So the author suggested that the results might be slightly positively skewed because there were some that had quite negative experiences that weren't able to participate. But this does suggest that there will at least be, in some cases, patients that are happy with this option. Moving on now to the analysis of college data. So this can be found starting on page 281 of the October Council materials package. What we wanted to do here, at least with the first set of data that's captured by that appendix, was look at trends in practice ownership and third-party affiliation with clinics. One of the questions that we asked, well, a couple of the questions that we asked were, how many clinics do registrants own? And how many clinics do registrants own and practice at? And what we were trying to better understand is, are we seeing differences? And it turns out that we are. So the dark blue columns here represent the number of registrants that own the number of clinics at the bottom. So 5,493 registrants indicated that they own no clinics, for example. And the light blue column captures those that are indicated that they own clinics and practice at those clinics as well. If you look, for example, at the 3 clinics category, you'll see that there were 204 registrants that indicate that they own 3 clinics, but there was a slightly lower number of 186 that indicated that they own and practice at that same number of clinics. As the number of clinics that registrants own increase, you see that less and less of them appear to be working at those clinics. And the one question this raised for us was, who's managing the day-to-day operations of clinics where, the owner has indicated they don't practice there? Do they have a partner? Is there a clinic manager or another registrant? Just a question, something that we are considering. The other piece of data I want to highlight is data related to third-party affiliation. So we asked registrants that practice in clinics, because some don't. We asked registrants, how many clinics that you practice in are affiliated with a third party? 84% of registrants, so over 8,600 registrants, indicated that they do not practice in a clinic with any third-party affiliation. So a DSO or a corporate entity. The other 16% noted that at least at one of the clinics that they work at, there is third-party affiliation. So in and of itself, this data doesn't necessarily lead to a lot of substantive findings. It's kind of a point in time, but it's something that we'll be looking to track over time to see if things are changing. The other thing that we looked at from a data perspective was referrals to discipline. So in recent cases where there were matters that are related to practice models that had been referred to discipline committee, we wanted to see if there were certain types of practice models that emerged, and there were two types that actually did. One is instances where a non-registrant or registrant own the facility in which dentistry is practiced, and where the non-registrants have responsibility for or control over the provision of administrative services within the clinic. The other is where aligner treatment was delivered directly to the consumer. Within some of these matters, there were allegations that registrants either convened the standard of practice, failed to keep records as required, treated without consent, or engaged in the practice of dentistry where the member had a conflict of interest. And this is all publicly available information. This is qualitative data. It's really helpful for us moving forward as we consider options, the types of issues we want to be addressing. I'm now going to move into the consultation feedback. This is probably the most substantive piece of research that was conducted and that we've asked you to review in advance of this meeting. You can find this piece starting on page 260 of your materials. First, I'll start off with a little overview of our approach. So we asked questions of different questions of different types of respondents. We first asked dentists and other oral healthcare professionals what non-clinical elements tend to be associated with their primary practice out of a list of 26 elements that we identified might have an impact on patient care. That could be positive or negative. More specifically, we felt that these impacts were related to access to care, continuity of care, or clinical care. We asked patients questions regarding what they value when it comes to accessing and receiving oral health care and the extent to which their experience in their usual clinic aligns with their values. And then we also asked all respondents for opinion-based feedbacks regarding the issues and opportunities related to corporate and direct-to-consumer dentistry. I'll note here that we received 595 responses overall, 357 from registrants or dentists, 168 from other oral healthcare professionals. So it was really nice to get the perspective of other health professionals that work in the same kind of practice model environments. And then 65 from members of the public and 3 from organizations. Of all the feedback we received, we did not hear from either a patient or a registrant that noted that a direct-to-consumer dentistry model was either their primary practice environment or their usual clinic or a clinic they had used. So just be mindful that all of the feedback on that model that we received through the survey is going to be opinion-based. Now I'm going to move into the quantitative analysis first. So this relates to that first kind of box there where it says non-clinical elements in their primary practice. What we did was we asked registrants questions like this. We put a statement saying, my practice generally X or my practice enables Y. And what we wanted to see was what was the response distribution between, very simple options. So yes, it does, no, it doesn't, not applicable or unsure. What we then did was divide the responses by practice model type because we really wanted to see if there were differences between the different types of practice models. I'll note here that as you can see on the right-hand side here with the legend, there are different response rate among the different types of practice models. We would expect to see more responses from those in solo or group clinics. We would also expect to see likely less responses from those in public or not-for-profit clinic environments, so hospitals, schools, public health clinics. But just be mindful that when we're looking at percentages there, those are percentages of the total number of respondents in each of those individual categories. This element here relates to fees that are listed in the current ODA or other oral health association fee guide for therapeutically necessary oral health care. And what we found is that most respondents, so 87% across all of the categories, noted that they do generally provide care that is based on fees that are listed within the current association fee guide. About 11% indicated that they provide care at rates that are less than that.
Amy, I'm sorry to interrupt you, but your volume has really decreased in the last few minutes.
Oh, it's
So I don't know if that's something that you can adjust or if we need to go through Aldwin to do that.
Oh, no, I can, I have some headphones here. Let me just plug those in and see if that helps.
Yes, I think already that seems way better. No, now we can't hear you at all.
Is this better?
Yes.
Okay, great. Okay, my
Yeah.
apologies for that.
No, not a problem.
So maybe I'll start over with this slide. So one of the questions that we asked was whether a primary practice generally charges the fees that are listed in the current ODA or other Oral Health Association fee guide. 87% of the respondents, so across all of the categories, noted that that is the case for them. There were about 11% that responded to a separate question, noting that they generally charge fees that are less than the Oral Health Association fee guide, but most indicated that they do charge at this level. Another element that we asked about that kind of paints a picture of some of the different types of responses that we received was regarding financing plans for patients. So we asked if their primary practice provides financing plans, and this was something that came up in the literature review as a way of covering costs for treatment that are might be beneficial for certain patients in certain circumstances. This one was interesting because the responses were split almost evenly between yes and no, but also across the different practice models. So about 42% of respondents said, yes, my primary practice does provide these options for patients across almost all of the models that were indicated here, and 45% said no. There is a difference there with the public or not-for-profit dental clinics category, as there was with the last slide. Again, when it comes to financial matters and public or not-for-profit clinics, their mandates are different, their operational structure is different. So seeing differences in response rates for this category on these types of questions was not particularly surprising. What was a little bit surprising was when we got into questions that relate a little bit more to elements that might impact clinical care. So does the registrant feel supported in their practice? Are they able to make referrals kind of at their discretion? Do they have access to all the types and equipment and supplies that they need? Or in the case of this question, does your practice have an identifiable radiation protection officer who works in the practice? We also asked about other types of leads in a practice, so an IPAC lead, a health information privacy officer. For this question in particular, what we saw was that there were quite a few more responses in the unsure category than other questions. So about 30% of respondents who identified a group private dental clinic as their primary practice, and 58% of respondents who identified a corporate dental clinic as their primary practice actually selected no or unsure to this question. So that was something interesting for us to see. The final example that I have here relates to the last question that we asked on practice elements, which we expected, based on our literature review, might have more of a negative impact on patient care. And this element was, my primary practice expects me to meet implied or stated production or earnings-based quotas. As you can see on the left, so under the yes category here, about 50% of respondents who identified a corporate dental clinic as their primary practice noted that their primary practice does expect them to meet implied or stated production or earnings-based quotas or targets. And this is compared with 30% of respondents from solo and group clinics, and I think about 22% for public or not-for-profit dental clinics. So this was something that was a useful finding for us. When we get into the qualitative analysis, so we had asked all dentists and other oral health care professionals follow-up questions on this multiple choice question regarding the practice elements. We asked them how they felt that these elements impact patient care. We asked them if there was anything they wanted to explain, so provide any nuance to their earlier responses, or if there were any elements that they thought impacted care that we didn't mention. There were over 500 comments that were received across these open-ended text boxes, and we've kind of consolidated them into 5 key themes here. So what I'm going to be doing is going through the key messages or takeaways from that feedback, and then providing a few different examples of the kinds of comments that we received. As it relates to business interests, the key messages that we took away were that financial targets or production quotas do not support care that's in patients' best interest. So this is what we heard in the feedback, and that patients can be provided with and billed for unnecessary treatments if business interests are prioritized over patient care. So we have here some comments. So the first comment would be from a respondent in a public health clinic where they noted that by removing the financial pressure to produce, dentists were able to focus on the services that they could provide. The next 2 comments are from those in group private dental clinics. So one noted that the owner was really concerned about expenses, and another noted, we don't have any quotas for our registrants. As it relates to practice management, the key takeaways were that the effective management of a clinic by office staff can really affect the overall functioning of a clinic, which can positively impact patient care. Conversely, it was identified that poor decision-making by office management, so some examples being screening out certain types of patients, changing treatment plans, or changing who referrals are sent to, can have an impact on patients' ability to access care, but also can compromise their quality of care. And it was also noted that where there's missing leadership roles in a clinic or high turnover of staff, that can create difficulties in the practice as it relates to consistency and quality of care. So under the practice management category here, there was an owner that indicated in a group clinic that they're responsible for everything. From a corporate clinic, someone had noted that, there are staff shortages and that makes training and turnover a bit more difficult. From a public health unit, one respondent noted that there is a manager of the clinic, but they don't actually provide a lot of oversight because they don't really understand how a clinic operates. As it relates to clinical and non-clinical autonomy, comments were made regarding some registrants not having needed supplies or equipment, and that may be having potential impacts in terms of delaying treatment or changing treatment plans. In some instances, there were comments regarding restrictions on referrals. So situations where a referral to an external specialist might have been intended by a patient's dentist, but that was circumvented either by the owner of the clinic or office management and then directed back to an in-house general dentist. And some of the examples that we have here kind of capture some of those things. So in a solo clinic, owner noted that they have total control of every aspect of a practice by a principal or treating dentist is crucial. Another comment noted that the principal dentist in their group clinic has the power to veto referrals, so as I mentioned earlier. And then there's a couple comments from corporate clinics that kind of show how you can have, within a practice model variation. So one registrant noted that they're allowed to practice dentistry the way they want and provide what they need for patients. There's no restrictions. And then another noted that they had some restrictions on the supplies and not being able to get what they needed. As it relates to access to care, there were comments regarding things that improve financial access to care for patients, so flexibility for dentists to maybe reduce fees on an as-needed basis, and the availability of payment plans to help support improved access to care. Interestingly, there were some comments regarding government-funded clinics and that, they have a very defined mandate, and so there may be instances where the eligibility criteria of the program through which a patient is seeking care might be restrictive. If they need care that does not fall within that eligibility criteria, it can mean that they, are asked to kind of be referred to a specialist. Maybe that specialist doesn't come to the clinic very often, or there aren't specialists that they're able to find within a range that they can afford. Some of the comments here again relate to 0% financing. So some registrants noted they provided, some don't. Some registrants in certain environments noted they do have to limit the number of patients they take on under certain plans. And then others noted, having this kind of flexibility to have different payment arrangements and change fees can really help patients receive care. The final element I'm going to speak to today relates to continuity of care. So the two comments that really kind of came out of all of the feedback on this theme were that when patients see different providers every single time they're accessing care, consistency in treatments and treatment philosophy can be more difficult to maintain. They also noted that seeing multiple different providers can result in a poorer understanding of the patient in some circumstances, can potentially lead to more errors, and can overall just have an impact on a patient's ability to trust and feel comfortable with their provider. The first comment here is one that really stood out to me. So a registrant in a group clinic noted that the modern dental practice has everyone working different schedules, referring to one another, and that it can be a challenge to keep everyone on the same page with the consistent philosophy of care. Someone in a corporate dental clinic noted that it can be less personal, providers are changing frequently, and this can cause gaps in miscommunication. And then a comment just noting that continuity of care can be more predictable when patients are scheduled with the same provider. So moving away from the practice elements now and moving on to patient perspectives. I don't expect you to read all of the lines here. We did ask the patients what they value when it comes to receiving dental care. So we had listed 20 elements here that broadly speaking fall into categories of financial or physical access to care, elements that might impact their personal experience receiving care or continuity, and then transparency about their practice model. What you can see, hopefully from the figure on the right, is that most respondents noted that these elements here were moderately important. So that's the light yellow color, important, light green, and then highly important in dark green. There were a couple responses where you saw a little bit of a shift towards a negative sentiment or those things being less important or not applicable. So for example, recommendations provided for cosmetic dental treatments shifted a little bit to the left. But generally speaking, most of the 62 patients that responded to this question, or those who identified as patients, noted that all of these elements are important. The other question that we asked was, okay, you've identified the things that are important to you. To what extent does your experience in your primary practice or your usual practice align with that? So we asked patients to identify their practice model and then kind of rank on a scale from, not applicable to, almost completely my experience aligns with my values. And you can see again, kind of a bit more of a tendency towards the positive. So a lot of respondents of the 61 that responded noted that their experience in their usual clinic either somewhat, very well, or almost completely aligns with their experience in their dental clinic.
Finally, I'm going to move on to the opinion-based feedback. So we received over 600 responses regarding the benefits and opportunities and issues and risks related to corporate dentistry. This was largely opinion-based feedback, but we did have dentists that identified corporate dentistry as their primary practice model, who also provided feedback here, and that would be based on their experiences. In terms of the feedback that's here, they're sorted from most commented to least commented on, and these are really the kind of top 3 in each category. In terms of benefits and opportunities, more timely and convenient access to care, greater financial access to care, and even greater continuity and more consistent care was suggested as a potential benefit. And that was largely as a result of patients maybe being able to go to different clinics within a network if they happen to be closer at one point in time or another. In terms of the issues that were identified, so things that we heard in the literature review that have focused on production of quotas and profit over patient care can lead to poor quality care and fraud, so things like unnecessary treatments, that a lack of patient-dentist relationships, which can reduce patient satisfaction and consistency of treatment plans, due to things like high staff turnover, and that there can be a reduction of clinical autonomy and or the control or flexibility to provide personalized care sometimes in these environments. With respect to direct-to-consumer dentistry, again, we received a lot of feedback, so over 550 responses. And again, these were from everybody, so those who identified as dentists, other oral healthcare professionals, patients, and organizations. The benefits for this model were suggested to be greater financial access to care and reduced costs for care for those who could already access treatment. So in the event where someone could afford orthodontic care, but they now have a lower cost option, that would be a benefit for them. Greater convenience and physical access to care, as I mentioned earlier. So for those in remote communities or who have health circumstances that make it more difficult to go into the office for aligner treatment, that it provides more options for lower cost and effective care, particularly for patients with simple concerns. But I will note most of the feedback here was in this kind of issues and risks category. So there was a sentiment from a lot of respondents that it's just generally risky. It can lead to quite poor treatment outcomes for patients, that there is no oversight or supervision of patient care to ensure that treatment progresses appropriately, which is a problem, and that you cannot properly evaluate a patient's oral health and establish a safe treatment plan without an in-person consultation and clinical exam by a dentist. So moving on now, I'm going to go to the last deliverable that was shared with you. So this is one that was back in the September materials package on page 137. And what we wanted to do here was something a little bit different. So with the other deliverables, we're better looking to understand the context and issues and opportunities. With the jurisdictional review, while there was some aspect of that work relating to issues and opportunities, we really wanted to better understand the approaches to address these issues. What approaches do other colleges take to regulate registrants that work in different practice models? So we took a very broad approach to this piece of the research. We looked at approaches taken by approximately 30 regulators and associations. And there's a variety of kind of different types of regulatory authorities that we looked at. Obviously, we looked at oral health regulators in Ontario, dental regulatory authorities across Canada and internationally. But we also looked at other other health professional regulators, both in Canada and other non-health professional regulators in Canada. So groups like the veterinarians, the college that regulates engineers, the college that regulates architects, and colleges that regulate lawyers. There were a variety of findings that are highly summarized or will be on this slide across 5 themes. The first relates to legislative frameworks concerning practice arrangements. So in some jurisdictions, so particularly the State Dental Board of Texas is probably the most prescriptive example that we found. There are examples where in legislation there have been very clear requirements set regarding what a non-registrant can and cannot do in an arrangement with a registrant. Another example of a legislative framework that came up was actually in Ontario, so with the College of Optometrists of Ontario, where they have requirements and regulation under their professional misconduct regulation for registrants to ensure that there are certain terms and contractual agreements when they are working with non-optometrists or non-physicians to make sure that they maintain their autonomy in those environments. So this would be the most prescriptive type of option that we could use if the college was to pursue something like this. It would make any new provision that we include something that's illegal for a registrant to do within a given practice arrangement. And so this is kind of at the most aggressive end of the spectrum. The second thing that came up was guidance. So things that we already do, guidance for the public or registrants, but specifically concerning direct-to-consumer services. A lot of this guidance, particularly for patients, is provided by associations. There's a resource in particular from the British Columbia Dental Association that various other associations across Canada have leveraged to help give patients some things to think about before they decide to make the decision to pursue this kind of treatment. And then there's also examples of some other colleges that provide advice to registrants if they're looking to get into this model, and in particular highlighting the standards that are of relevant importance or particular importance to this type of environment. The third relates to something that is a little bit more on the ethical side. So professional and ethical expectations for balancing business interests and patient care. Across the dental regulatory authorities in Canada, you will see at least one provision that relates to business arrangements and making sure that registrants are aware that they must uphold their legal, professional, and ethical expectations, regardless of who they're in a contractual relationship with. But the College of Oral Health Professionals in British Columbia, they kind of took this a little bit further. So they created a document, includes standards and guidelines that specifically address the provision of patient-centered care with business interests kind of being present in the background. They acknowledge that business interests are going to be there, but that the priority must always be making sure that care is provided in patients' best interests. And so they provided some requirements and guidance on that topic. The fourth theme that came up the most frequently across all of the research, and this is facility-based legal and or professional expectations for registrants. So we've seen across fields such as medicine, pharmacy, veterinary medicine, and even dentistry in some other jurisdictions, there are requirements for a lead registrant in a practice to oversee operations to make sure that they're in compliance with all existing requirements and rules. The final example that I have here is actually a little bit more on the opportunity side. There's also an element of risk mitigation, but what we have here is use of a regulatory sandbox to test practice models with the potential to improve access to services. So this is a scenario where a regulator may choose to, as part of kind of a time-limited program, alleviate or bend or provide exemptions to proponents of a particular project, bend the rules a little bit, bend their own rules, to allow a project to be tested in a very controlled manner in a very controlled community over a very defined period of time. It allows them to better understand how this model might work, where there might be benefits for patients, and also where there might be risks. And it helps give them information so that they better understand how to regulate those risks or address those risks through regulation. So these were the 5 key themes that came out. So these are kind of options that we're considering in conjunction with the issues and opportunities to figure out what make sense for the college based on what we've seen. The final thing I'll note, I'm not really going to speak too much on this. I know Dan's mentioned this today already, but we are also keeping track of the College of Pharmacists. A key priority of their strategic plan for the next 4 years is really to address corporate pressures in pharmacy. And so they're exploring a variety of possible solutions across these 4 categories that I have here. So we're just keeping an eye on things they're doing, seeing where there's maybe inspiration we can draw from them, or there's opportunities to align. So that's it for the first part of the session. So now we're going to move into the open discussion. The first item here, I see actually Dan has his hand up. I don't know if you want to jump in.
I do. And thank you very much, Denny. I just wanted, just before you go into the discussion, and there may be some comments, but first of all, I wanted to congratulate Denny for getting through a lot of information. And we realize this is a lot of information for you. It is probably one of the most studied areas that we've done in terms of the jurisdictional review, the research, the literature, the consultation. And we're not putting any pressure on you for decisions today. And we're open to your comments about how you can digest this information. We want you to sit with it for a couple of months. And when we come back in December, we're going to have more discussion about it. But obviously, there might be some pieces that you'll focus on today. Give us your reaction, and we're going to ultimately come back to you with options. What do we do? But that's not today. And I wanted to just sort of alleviate any pressure you might feel from thinking that you had to absorb all of that today. And we will work with you to make sure that you have lots of opportunity to consider this information. So I'll turn it back to I'm not sure if Hanno, you will guide a few questions, or if Denny, you want to get those questions through this particular exercise.
Yeah, I think maybe maybe we can just jump into item 1 because that's really just asking for any comments or questions that you might have on the material that has been shared. I know we don't have a lot of time today, but I also do want to note that my email is in the briefing notes. So if you have any questions or comments that we don't get to, or that you think is more appropriate to share with me over email, I'm happy to take those as well. So I'll just open it up, I think, at this point. I'll note for the next 2 questions, I do have kind of a board that I can put up to kind of gather your feedback in a bit more of an interactive way. But for this one, I'll just leave the slide up.
Deborah.
Thank you. Excellent presentation and very detailed, very impressive. Thank you, Denny. My question is, I just want clarification. Was most of the samples from the questions asked from dentists participating in practices in Ontario, or was it all of Canada?
That's a really good question. So the consultation feedback was exclusively from dentists that were in Ontario. At least that's how those that self-identified in the demographic portion noted. Some registrants or those that filled in the survey don't actually get to that demographic portion, but of those that did, they were in Ontario.
And what percentage of dentists practicing in Ontario did respond to the survey?
That's a good question. So through the annual renewal, I think there's about 10,979 roughly registrants that renewed for 2024. In the survey, we got about 300, maybe 57 responses from dentists. So I would say it's maybe a lower percentage out of the total number of registrants. But I would say for some of the surveys that we put out, it was quite a high response rate.
Okay, thank you.
Nalin.
There, yeah. Well, thank you. Thanks, Danny. So one thing I noticed, there was a category in some of the questions you asked about clinics owned by non-registrants. So clinics owned by non-registrants. Do you think the RCDSO should register them somehow? Because that's saying there's clinics that we have there's no way to monitor them.
That's a good question. I think like the concept of clinic ownership and who can own clinics and how that works in our oversight over clinics is definitely something that we're thinking about. I know in some other, across Canada, I would say generally speaking, anyone can own the physical office. So you will see corporations that own clinics across Canada, and they own the physical office. They can own the supplies, they can own the equipment. They can't obviously own the business through which dentistry is practiced, but they can be a landlord to a dentist, for example. So that's something that's fairly consistent. What we have been thinking and kind of a little bit along the lines of what I mentioned with respect to facility-based requirements is that in some health professional colleges, you will see that they have accreditation of facilities. So they can actually go into the facilities, inspect them. And I believe the pharmacists, they already have an accreditation framework. And so they're looking to leverage that to gather more information to inform how they regulate registrants. So there are kind of frameworks related to ownership. There's other things related to a clinic that we're considering. And I think those things will come out in a bit more detail when we come to you with options.
Thank you. Osama.
Hey, everyone. So great presentation. I have a question regarding, so the qualitative component of this, and I believe there were five aspects I believe that you had from the qualitative component. Is there, I kind of would have liked to see a little bit more information as the qualitative aspect of this, how it relates to more of the data and the quantitative questions that we could ask from that information. So to give you an example, continuity of care, for instance, as we see patients, can we collect, for instance, data from ICRC as it relates to complaints relating to continuity of care? Like, let's say a patient sees multiple practitioners in the same office. Are those patients more likely to have ICRC complaints? And is there data on that specifically? that to me would be at least one important question that we can ask and gather some more data points. Do we have information on that?
So we do have, I guess, as a policy team, the ability to look into some of the issues of ICRC data. So that was one of the things that I looked at, not specifically the continuity of care piece, but that is something that we can do. I think the challenge as it relates to practice models is being able to tie the complaint to, we can tie the complaint to a registrant. It's very challenging to tie a complaint to a practice model. It's one of the things we would have liked to do ideally, is take all of the complaints, tie each complaint to a practice model and see if we do see things like, do we see more continuity of care related complaints in a corporate model compared to another model? At this point in time, we're not able to make that connection. Again, we regulate registrants, we don't regulate facilities. So there's it would be a bit of a challenge to be able to do that. But I think one of the things we're considering are opportunities to maybe improve our data collection processes moving forward. So that way we can kind of investigate issues on maybe a practice model type basis moving forward. So that would be one area I can keep track of.
I think the only comment I kind of, maybe I didn't clarify specifically, but I just gave one example, but I think the next kind of step in this would be to how to take the qualitative information and to create some quantitative questions that we can actually answer.
Okay, thank you. I'll take that
Thank
back.
you.
Thanks, Osama. Peter?
Thank you. Thank you, Denny. Question for you. I'm wondering specifically about direct to consumer corporations. And when a direct to consumer corporation fails, I'm wondering, what challenges does that present to our college? And is there anything special that we can learn from the one that failed not too long ago? Thank you.
It's a good question. I know that when that one direct-to-consumer dentistry company that you're referring to was effectively shut down at the end of last year, we did release communications via a newsletter to registrants to provide some very general guidance regarding treating or managing patients that came from that model. So we did provide some kind of high-level guidance or advice. So that way, if registrants were starting to see an influx of patients that were coming to them, maybe partway through orthodontic treatment through that model, that they would have a better sense on how to manage patients. So that's one thing that we did to try to get at that.
Thank you. Anthony Mayer?
Thank you, Hannah. I just want to commend Denny on a really thorough presentation, a lot of material. As the only orthodontist remaining at the table, I just thought I would comment on the direct-to-consumer orthodontics, and that company that did the majority of those services actually did close, and there were a number of patients that were sort of orphaned and left stranded. Some of them were able to pick up with other practitioners, and some of them just abandoned care. But there's another element to this, in that several jurisdictions in the US, I don't know how many, but there have been a few, have actually banned this model completely because of the number of complaints that we're seeing. So it's several states in the US no longer allow that kind of direct-to-consumer orthodontic care. Thank you.
Thanks, Anthony. Mark Trudell?
Thanks, Mano. Denny, thank you to you and your team for a very informative presentation, and I commend the leadership team to table this topic for discussion today and going forward, because I think it's extremely timely and extremely germane to the college. Denny, if you could throw up the previous slide just to guide council and just on some of the talking points I wanted to share with folks, with council. Actually, I think it's the key findings slide. There we go, the themes. theme, I'm going to focus just my point I want to make is on theme number 3. And also theme number 5. I think the college has certainly a key role and a leadership position to take in as this topic evolves, and that is the topic of ever-evolving practice models, corporate practice models, ownership of a practice by a corporation whose shareholders and arguably whose directors and its governance may be populated by non-dentists. You had mentioned that you had looked to other colleges outside of the healthcare sphere. For example, I think you even coincidentally mentioned engineers and architects. I wanted to share with council just to reflect on that topic in terms of opportunities for not reinventing the wheel, but building upon pre-existing models in other professions. In the profession of engineering, when you're in providing services to the public that have the potential for significant public harm, there's a requirement in place that the corporation responsible for the delivery of the service, who employs, be it architects or engineers, must be registered with a licensing body. And it is held to the same standard as the licensed entity, the engineer, or in this case, the dentist. So that is to say, it deals with the theme of profitability and the balance of service delivery and the patient and the public's best interest to be safeguarded by ensuring that both the corporation that may own beyond the physical plant, but the practice, in addition to the dentist employed by the corporation, both that accountability applies to both. It's not offloaded all on one shoulder or vice versa. So I think this is a very dynamic environment, very dynamic business environment. We're witnessing this evolve on a weekly, monthly basis, and I think we should be as a team dealing with this forthwith with the best interests of the public at hand. And I recognize that's a lot of heavy lifting because I believe it will require statutory amendments, regulatory amendments, in addition to policy change and so forth. Thank you for the opportunity to comment. And apologies, internet lost connection. I'm really pleased that I was able to chime back in for this session. Back to you.
Thanks, Mark. Dan?
Yeah, thank you, Hanno. Just to maybe comment on a couple of things that have come up from various speakers. I guess, I think Peter asked about some of the challenges for us. I think it was Peter. And, throughout all of the different changes in whether it's direct to consumer, different practice models, corporatization, anything else, we're always challenged by looking to see, is in direct to consumer maybe a better example, but is it practicing dentistry? Is there something in here that's about practicing dentistry? Is there something in here that would suggest we have or don't have authority to do anything? And at the end of the day, and I think Denny put this up in the objectives at the very beginning, what is it that we're trying to do? What is it that we're trying to address? What is the problem we're trying to solve? Our goals are simple. They're two things. We want to assure the quality of practice for patients, and we want to be able to effectively regulate. And right now that's dentists, and apropos to Mark's comments, it might be wider than that. And in a shifting landscape where we see different models of practice, regulation has a tough time sometimes keeping up. So can we identify solutions that will apply regardless of the model? And I'm not suggesting that we'll be able to anticipate everything, but are there ways that we can approach this differently than maybe trying to chase something all the time? So we really have to be mindful of our authority and what it is that we can do that might overlap with different practice models that achieves those two objectives, quality of care and effective regulation. So again, this is a strategic project for a reason. This is big. And we certainly will have lots more time to talk about the options or how we move forward. But I just wanted to try to close the loop on a couple of those comments.
Thank you. Anthony Lisho?
Thank you very much, Hanno. My comments are, first of all, Demi, thank you for a very, very comprehensive presentation. My first thought is that DSOs have existed for quite a few years. This material goes back, I don't know, correct me, maybe 4 or 5 years, something like that. I'm wondering what percentage or what material or what knowledge that we had from 15, 20 years ago that sort of building on what Dan just mentioned, have we been able to build on? Because we know this was coming and we're here now. Previously, it was something that was controllable because the numbers weren't as huge as they are today. But this is really the Wild West right now. And I think we're at the, I shouldn't say pinnacle, but perhaps, and there's a certain limit to where corporate dentistry is going to go. And that's been evidenced in the States. And perhaps we can take the page, and you've already mentioned that we're doing that, out of health professions that have gone this route before. The one that comes to my mind is pharmacy. You know, the mom and pop pharmacy is long gone. Way before DSOs came into being for dentistry. And perhaps we can continue, and I know you said that you were going to do that, but have we been keeping, like, has this been a continuum from the time the first DSOs existed? I remember one particular one had 4 practices. In fact, I was doing a locum for this one particular individual, no names mentioned, of course. And then all of a sudden, now we're talking about, I don't know, and 500, 600, maybe 1,000 practices, especially with the most recent merger and acquisition. But so I'm hoping that we don't lose track of the information that's come along from sort of day one and continues. And as Dan said, we have to stay on top of it. We can't just sit back and react. We have to be proactive. So those are my comments, and thank you very much.
Thank you. Harinder.
Thank you, Hannah, and thank you, Danny. Mine is just a comment. I think I'm not speaking in favor of corporate dentistry or against it. I have had the opportunity to speak with the legal advisors of one of the DSOs. And that person was very much informed and concerned about some of the things which might be being labeled on DSOs. And they are actually looking toward the college to come up with the rules of engagement and how DSOs are going to work in Ontario or in Canada. And I think at some point when we are a little bit further in this discussion, I think bringing them in will be a very useful thing. And I think leave aside the profit side or the corporate side, but they do have legal advisors who are very much interested in following the college direction and keeping them above board. Thank you.
Thanks, Harinder. Osama, you were on my list. Oh, you're back on my list now. Take it away, Osama.
Yeah, sorry, I was last time I was talking, I got a little cold. So but I kind of did want to reiterate what I was saying earlier, in that it does kind of tie back to the different comments, and the way I see it is there's kind of a tug of war between access to care and quality of care here. And you know, when you look at it, you should think, well, they should kind of be on the same side. But really, as access to care increases, there's a question and around the quality that's of the care or the service that's being provided by the practitioner. So it's in order to really kind of discuss this further, to really ask the right question. We have to ask the right questions. And so this is a great start. It's a great presentation. It's eye-opening in terms of some of the qualitative information and the comments that were coming back. But we really have to look into those qualitative components that we figured out and the themes. We really have to gather some really, really good data on this, and there has to be appropriate questions. And just to give the example, one of the questions is with regards to continuity of care. So as a specialist, we do see a lot of patients who will end up seeing us, and the first comment we'll see is from the patients that they've seen multiple practitioners in the offices that they were coming from, and from that, whether there be this is the quality of care component. So without giving without giving more examples, I think it's super important to make sure that now that we know that there's a qualitative assessment here, what are the real questions that we have to ask are related to, are there ICRC complaints that are coming out of this? And can we trend that over time? And to go back to what Anthony was saying was, this has been around for 15 years. So can we go back to those complaints? And has there been a upward trend with regards to this, and really kind of collect information over time? And we may not find that there's any difference. And from that, then we can go back to what Dan was saying and maybe find some more concrete practice themes that are applicable to all different types of practices out there, whether it be a corporate model or a single practitioner model or multi. Thank you.
Thanks, Osama. Brian.
All right, thank you. First of all, my thanks to Denny and everyone involved in bringing the discussion paper forward to us. As a public member, I think, as has been reflected in others' comments, the focus on quality of care going forward, assessing the quality of care, not just more is better, but is it accomplishing what we want for the patients, and the regulations that will flow from that, I think, are good. Very, very important that we're doing this work now. Talk about a proliferation of business expansions. I live in a relatively small community in Belleville, and the one thing I have noticed is that there's more dental offices now than we've had in the 25 years. So that's a good thing, but we want to make sure it's meeting the and serving the public effectively. And my compliments to everybody for bringing this forward to us, and we'll look forward to seeing further results as time goes on. Thank you.
Okay, last speaker on my list, Anthony Lisho.
Thank you, Hanno. Just to comment on Brian's comment right now, and some of the other ones, Osama, as well. One of the reasons why we are where we are today is because dentistry as a business is one of the most profitable business that people can invest in. For example, a dental practice today, when going to the bank, the individual or individuals going to the bank to request funding, the banks will usually fund almost 100% of the cost of the value of the practice, or even the 5 or 10% premium on that appraised value. So when you're looking at returns of anywhere from maybe a minimum 13% to possibly over 20% return on their investment, that's a huge business opportunity. There aren't many businesses out there that can that are in that environment. So let's keep that in mind, that the reason that this is going to escalate more and more, and we have to be on top of it, as Dan pointed out earlier, is that it will keep growing. There will be a limit, as there has been in the United States, as I said earlier, but it's the profitability, and it's not so much the art and science of dentistry anymore, but I think it's the art of business now. Dentistry is the art of business. Thank you.
Thank you. And thank you, Council, for your considered questions and comments. And thank you so much, Denny, for coming today and for sharing with us your research. I know, and we look forward to seeing you again as this research continues and as this discussion continues. So thank you for attending today.
Thank you.
The next item on our agenda, we've already dealt with number 10. We're going to move to item number 11 on the agenda, which is a presentation by Susan Taylor, and this matter concerns a new resource guide, clinicians in their treatment decisions and communications with patients about antibiotic use. The materials for this item are on pages 292 to 311 of your meeting package, and this is an item for Council's decision, and I'm going to turn it over to Susan now to walk you through the material. Susan, please.
Thank you, Hanno. And I just want to make sure that folks can see my screen.
Yes, we can.
Yes. Okay, perfect. Thank you so much. And thank you for the opportunity to bring this item to you today. I do have a very brief presentation. It's about 6 minutes long, and then a chance for some discussion. So I'm here today on behalf of our working group to share with you a chairside tool that's been designed to guide clinicians in their practice and to give them practical tools to communicate with patients. You'll notice some familiar names in the working group, and that participants include dentists, family physicians, infectious disease specialists, and quality improvement experts. This work has been sponsored by Choosing Wisely Canada and has adapted proven practices in improvement and implementation science. The request before you today is twofold. First, we're asking Council to agree to adding the RCDSO logo to the resource, Taking the Bite Out of Tooth Pain, a toolkit for using antibiotics wisely. And second, we are asking that the College agree to disseminate the toolkit to dentists in Ontario. Antimicrobials are medicines that are used to prevent and treat infectious diseases in humans, animals, and plants. Antimicrobial resistance occurs when targeted organisms no longer respond to medicines. AMR is a natural process that happens over time through genetic changes in pathogens. Its emergence and spread is accelerated by misuse and overuse of medication. As a result of drug resistance, antibiotics and other antimicrobial medicines become ineffective and infections become difficult or impossible to treat, increasing the risk of disease spread, severe illness, disability, and death. Antimicrobial resistance is one of the top global public health threats. The World Health Organization estimates that bacterial AMR was directly responsible for 1.27 million global deaths in 2019 and contributed to almost 5 million deaths. The data shows that approximately 10% of antimicrobial prescriptions come from dentistry, and that many of those may not be clinically appropriate. The toolkit I'm presenting today addresses tooth pain and highlights that in most situations, a patient who presents with tooth pain doesn't require antibiotics, but that their pain can best be addressed by addressing the underlying cause. The College is engaged in concurrent activities to support appropriate antimicrobial use, ranging from beginning to understand variation through the data, to raising awareness through continuing education courses, and using our regulatory levers like the Practice Enhancement Tool, adding exam questions that target knowledge in antimicrobial prescribing. Today's item focuses on tools and techniques supporting practice improvement, specifically the proposed Choosing Wisely toolkit. The toolkit has been developed with support from Choosing Wisely Canada. Choosing Wisely is an international movement spanning 25 countries and 5 continents. Choosing Wisely Canada recently celebrated its 10th anniversary, marking 10 years of working with experts in many fields to reduce unnecessary tests and treatments. Launched with the tagline of "More is not always better," Choosing Wisely encourages conversations between clinicians and patients about the care required, posing questions such as, do I or does my patient really need this test, treatment, or procedure? What are the downsides? Are there safer, simpler treatments? And what happens if we do nothing? Given that we know that much of antibiotic prescribing is rooted in a desperate desire to alleviate symptoms, there is alignment between Choosing Wisely Canada and this particular initiative. You received a copy in your package today of the toolkit, and please note that the version you have is still in draft and has been shared for reference only. Please don't be alarmed by the formatting. The document has not yet had any graphic design treatment, and likewise it's still undergoing editing, particularly in areas that are patient-facing and require plain language. One of the first things you may have noticed was the toolkit is based on a target audience of dentists and physicians, as well as their patients. The reason for this is that we know that sometimes patients present first to an emergency department or a family doctor's office, and sometimes don't actually have a dentist or don't have access to a dentist at the time that they need them. We wanted to be sure that we weren't limiting the spread of knowledge, and so have positioned the resource more broadly. A hallmark feature of any Choosing Wisely product is that it seeks to support communications between clinicians and patients. There are patient-facing materials designed to draw attention to the issue of antimicrobial effectiveness and the risks associated with overuse. At the same time, the toolkit provides resources to help the dentist respond to the patient's concerns and support them leaving the office feeling that they've been heard. I want to highlight that the resource aligns with RCDSO's role to protect the public. By providing education that increases appropriate prescribing, it reduces the risk that may arise directly from a dentist's interventions. And at the same time, by addressing patients directly, the toolkit engages and educates patients about the risks to them individually and to the public overall. I also want to note that the toolkit will be published in both French and English. Structurally, the toolkit builds on the successful COLD standard, a Choosing Wisely resource that targets respiratory infections and is now in its 5th iteration. Like the COLD standard, the toolkit is peer-reviewed, chairside resource that includes decision aids for prescribing antibiotics, a prescription pad for symptom management, office posters to raise awareness, and frequently asked questions for patients and healthcare professionals. The working group is moving very quickly to develop the content shared in your package. The content is planned for launch at the same time or in conjunction with the World Antimicrobial Resistance Awareness Week that's scheduled in November. I'll conclude this brief presentation by saying that the toolkit is only useful if we can get it in the hands of the clinicians who are caring for patients. Once launched, we are counting on partners and dental regulatory authorities to help us spread the word to dentists across the country. We're asking for the RCDSO's endorsement and permission to use the RCDSO logo on the toolkit to signal your support of this important resource. We'll provide information and links, and we'll be asking for the college to share through its usual channels to all provincial registrants. So thank you for your time and attention. I'm going to pause here, stop sharing, and I'm happy to answer any questions.
Thank you, Susan. Daniel Haas.
Great. Thanks so much for that presentation, Susan. And also, I think this is great. I think the initiative is really wonderful to see. Thanks for leading it on behalf of the college. I have a couple of questions and a few comments. You mentioned that, and I saw in the documentation, the partners and the endorsers of the initiative. Have you contacted Western Canada One Health? They, as you might know, they're a very professionally diverse group from the Western provinces, and they're really doing the same thing. I think, as I mentioned, they invited me to speak at the meeting in Vancouver a few weeks ago. So they wanted to, where is dentistry with all of this? They're very interested in collaborating. And linked with them is the BC Centre of Disease Control, and they already have sponsored some YouTube videos on antibiotic prescribing in dentistry that are very well done. They're very clear. They're very short videos, and it's done by Clifford Powell from UBC. So you may want to consider links to those in the documentation as well. But I'm just wondering, have you considered reaching out to Western Canada One Health?
We haven't actually reached out to Western Canada One Health, but that certainly is a great idea, and I'll take that back to the group, and we can do that next week.
And then, if I may, Hannah, just I have, and I don't want to take up council's time with this, but there are 4 areas of content that either need to be corrected or modified. And again, I don't want to take up everyone's time with this. Can I email those to you and
absolutely
for consideration, because they will need to be edited?
Yeah, absolutely. If you want to email those to me, or if you want to have a call, we can arrange that after.
Okay, great. Thank you.
Great.
I'll do
Thanks a lot.
Thanks.
Thank you, Daniel. Jamie.
Yes, thank you very much for the presentation. I know you've worked on this, and I'm just wondering, how do you intend to go to the dental schools for any sort of endorsement, and certainly education in the early stages of practicing dentistry is probably a good route to go. Susan, I'm not sure what you think.
I know in Ontario, we have very close connections to the dental schools. I can't speak on behalf of the other provinces, and because this is a pan-Canadian initiative, then I think there may be some different strategies in different areas, but we will certainly be ensuring that the two faculties of dentistry in Ontario are informed and that this is shared with them.
Thank you. Nancy?
Thank you, Hanno. Susan, what a great presentation. Thank you so very much. I don't have a question, but I just wanted to comment and state openly my full support and how much I welcome this toolkit for using antibiotics wisely. You know, and I think I shared this with you and Dan at our previous meeting. I get confronted with prescribing antibiotics for total joint replacement. And, you know, it's something that changed years ago, and yet it's still prevalent. So thank you, thank you, thank you. And I fully support it.
Thanks, Nancy.
Thank you. Osama?
Thank you. I'm not sure if this was discussed already, but so if you go to the toolkit, like on the website, choosingwiselycanada.org, and then when you go to like recommendations, we're not listed on that. Is that what this is all about? Like we're going to get listed on there now, or like there's no like you could see all the medical specialties, and then you see like nurse practitioners, nursing, oncology and stuff. But I only see hospital dentistry.
Yeah.
Will this be now where there'll be recommendations for outpatient dentistry?
That's a separate piece of Choosing Wisely, is where they've come together with different groups of experts. And you're right, there is a group of hospital dentists that is part of that. And those groups of experts have come up with recommendations. There isn't currently one for community dentistry, and I think that would be fantastic to move towards. This is a first step by saying that this is a resource that is targeting dentistry, because there hasn't really been a lot available for dentists through Choosing Wisely. So what we're asking is to have the RCDSO logo on the toolkit. And then I think, to your point, it would be wonderful to proceed with seeing what we could do to create a community dentistry group to come up with recommendations.
Thank you. Daniel?
Sorry. And just sorry,
Oh,
and one more thing. Sorry, just one more thing to add there. And the hospital-based dentistry, like the recommendations that are there, I would highly recommend that they get revisited as well, just because I don't think they are updated.
Right.
Thanks, Osama. Daniel?
Yeah, just a quick comment on something Jamie had mentioned about the school's involvement. The schools have already been teaching this for some time, and even with continuing education courses, it is being taught, but it does get lost in practice for various reasons that have been picked up. A lot of this is behavioral change to get out of the habit of always doing it a certain way, or for doing it out of concern that it's quote unquote safer to prescribe, not prescribe. And the value in having the RCDSO doing this is my own opinions. I think people will listen if the RCDSO is saying, hey, folks, this is what you should be doing. I think they carry much more weight than the schools do. So that's why I think it's so valuable to have the college involved in this, saying, you know, you really need to look at this, because I think that'll get everyone's attention. Thanks.
Thank you. Anthony Lisho.
That's amazing, Susan. Thank you very much. Not only with what you've presented, but I can see this expansion to other aspects like drug interactions. And it prompted me to pull this out that I've had for years. And I don't know if it's visible there.
It's not, Anthony, with the screen
Okay, it doesn't matter. It's the ultimate cheat sheets, the practical guide for dentists, and it talks about drug interactions and the prescribing of antibiotics, analgesics, all sorts of stuff. And so I think it's a very, very important steps, and I think it's something that we can build on and incorporate other aspects of prescribing and interactions for the future for dentists.
Thank you, Anthony. I have no more speakers on my list, so could I ask to have motion number 3 put on the screen for council's consideration, please? And motion 3 is that council approves the request to endorse taking the bite out of tooth pain, a toolkit for using antibiotics wisely, and the addition of the RCDS logo, and that the toolkit be distributed to registrants and the public. That's moved by Daniel Haas, seconded by Daniel Lisho. This just requires a simple majority, so please indicate yes by raising your hands. And that motion is carried. Thank you very much. Next item on the agenda is a discussion in regard to the practice advisory on the release and transfer of patient records. This matter is about an update that has been made to the practice advisory relating to the fees that dentists may charge for the duplication and transfer of patient records. The materials for this item are on pages 312 to 314 of your meeting package, and this matter is for your information. And I'm going to ask Cameron Thompson, Manager of Standards and Strategy, to walk council through the update. So Cameron, I'm turning it over to you now, please.
Great, thanks, Hanno. Hi, everyone. So as you've heard, this is for information. The sort of relevant details are captured in the briefing note, as you've heard, on page 312 of your materials. I'll keep my comments relatively brief because I think this update is fairly straightforward, and I think the briefing note captures the relevant details. But in a nutshell, we've made a minor update to the release and transfer of records practice advisory based on information that recently came to light, which sort of made it clear to us that the guidance that we've historically set out for dentists concerning the fees that they can charge for copying and transferring patient records was not sort of entirely correct or entirely aligned with relevant provisions within legislation. So the fees that dentists can charge for records are not decided by us. They're governed by legislation, and they're enforced by the Information and Privacy Commissioner of Ontario, and sort of more granular detail on this is included in your briefing note. But basically what the legislation anchors to is the cost of reasonable cost recovery, which in some cases may fall below a dentist's customary fees or the direct costs incurred by the dentist in producing the copies and making the transfers, which is what our practice advisory has historically stated. So the upshot of this is that our guidance, if unchanged, could have left dentists open to a complaint to the Information and Privacy Commissioner for charging fees that were in excess of what would be permitted under the legislation or what has historically been permitted by the Information and Privacy Commissioner. Sometime over the next few years, there will be a more fulsome update of the practice advisory. But until that time, we felt, given that we'd identified an important problem with the current practice advisory, we felt that it was important to sort of introduce a temporary correction in the interim. And I've heard that some folks have had some difficulty seeing the updated practice advisory by the link in the briefing note. I think we've resolved sort of the issue that was causing that problem in the back end. But what I'll do really briefly is just share my screen so that you can see exactly what that change looks like in case you haven't had an opportunity to see it via the briefing note. I trust you're able to see this, and the relevant update is here. It's this box that's effectively been crossed out, and then the notation that's been added, advising readers, dentists principally, that the particular guidance in the former practice advisory is no longer in effect, and directing inquiries to our practice advisory or to the Information and Privacy Commissioner if dentists are unsure what fees they're permitted to charge. A sort of more recent update, this is a development that's occurred since the council materials were shared, is that our practice advisors working with staff at ODA have been engaging with the IPC to develop a more complete picture of what reasonable fees might look like. And so our practice advisors, I think, are well equipped to respond to questions from dentists if they come in. And so that's effectively the update, but I'm very happy to take questions and respond to feedback if anyone has any.
Thanks, Cameron. Are there any questions from council members for Cameron at this point in time? Cameron, I'm not seeing any, so could I ask that? Oh, this is just information. So thank you again for attending and for walking us through that, Cameron.
My pleasure.
And the next item on the agenda is in regard to the departure of Dr. Eckler that Dr. Sandhu referred to earlier in his presidential report. The departure has created a temporary vacancy in District 4. The material for this matter was distributed separately after the distribution of the council material, and this item is for council's decision. And Dan, I'm going to turn it over to you to walk council through this issue, please.
Thanks, Hanno. So as Hanno said, the material was distributed after the materials were first delivered to you. So hopefully you have it in front of you, but I'll walk you through quickly. With Dr. Eckler's departure, it leaves a vacant seat for District 4, obviously. And because we are, I think by my tally, about 6 or 7 weeks away from the general election for districts, we are within the category of a short-term vacancy, which is less than 6 months from the general election. And the bylaws point out that there are 3 options. You can leave the seat vacant, you can appoint someone, or you can hold a by-election. Because we are so close to the next election, it would be staff's recommendation that we leave the seat vacant. The other 2 options are to appoint someone or to hold a by-election, both of which would probably result in timing that would not allow for either of those 2 options to be concluded before the election. And in addition, if you were to appoint someone, I think given the fact that we are a week away from announcing the slate of candidates for each district, it would be disruptive and likely unfair to that election process. So we have provided you with Dana Simon's help and Alan Bromstein with the options and a full analysis. But because of where we are in the calendar, it would be our recommendation that the seat be left vacant. But I'll turn it back to you, Hanno, if you can facilitate the discussion, and then there's a motion to this effect as well.
Thank you, Dan. So any questions or comments for Dan at this point in time? Seeing none, could I have motion number?
There is one.
Sorry, Judy. Judy, you're muted.
Okay, thank you. Yes, I just wanted to say that I think it's the most sensible decision to make, and I'm going to fully support it. It makes no sense at all at this point in time to have an election for District 4.
Thanks, Judy. I see no other speakers, so could I have motion 4 on the screen, please, for council's consideration? That council approves leaving the council seat in District 4 vacant for the remainder of the current term. That's moved by Anthony Lisho, seconded by Mark Trudell. All those in favor, please raise your virtual hand. Please raise your virtual hand. And that motion is carried. Thank you very much. We've now come to the end of the formal agenda of today's meeting. Staff would like to propose that we move to an in-camera session. After the in-camera session, we will resume the full meeting, but for the sole purpose of adjournment. For our in-camera session, we will have just our council members along with the registrar and deputy registrar, senior staff, as well as council Alan Bromstein. And if I could have motion number 5 on the screen, please. And council, that council exclude the public from the meeting pursuant to clause 7(2)(b), as financial or other matters may be disclosed of such a nature that the harm created by the disclosure would outweigh the desirability of adhering to the principle that meetings be open to the public. And that's moved by Judy, seconded by Vivian. All in favor, please raise your virtual hand. And that motion is carried. Thank you very much. So we have come to the end of our public agenda today. A brief reminder, Council, that our next meeting will be another virtual meeting and will be held on Thursday, December 5th, 2024, from 9 o'clock until 4 p.m. Thank you, Council members, for the discussion and your participation today. And I would be remiss if I didn't do a shout out specifically to staff, the staff that we see here, but particularly the staff who work behind the scenes, whose faces we don't see, for the incredible effort and work that you put into the running, the smooth running, and the preparation for these meetings. So our appreciation to staff for that. Before we begin, I'm going to suggest it is now 11:56. I'm going to suggest we take a very quick bio break and that the in-camera session begin at 12:05. So if you just turn off your cameras now, and we will begin our in-camera session at 12:05. Thank you.